Now, when we talk about any anatomical structure, there is always an importance regarding its function, and girdle's function actually revolves around the movements that are possible at it. And there are movements in terms of all three degrees of freedom or all three planes, and that's what we are going to take a look at in this lecture. So we're going to talk about the movement or motions at the pelvic girdle or the pelvis in terms of the three planes and axis. We're also going to take a look at the pelvic tilting, both anterior and posterior pelvic tilting and lateral pelvic tilting, and the pelvic rotation as well. We're also going to talk about the force coupling and the muscular action in pelvic girdle motion. So let's talk about the pelvic movement in the sital plane. So the movement possible in the sital plane is the anterior pelvic tilting or the posterior pelvic tilting beyond the neutral. So in neutral, the anterior superior iliac spine and the pubic symphysis should be in the very same vertical line. Whereas in the anterior pelvic tilting, the anterior superior iliac spine moves anteriorly and inferiorly, and that results in an anterior pelvic tilting and increase in lumbar lordosis. Whereas in posterior pelvic tilting, the anterior superior iliac spine moves superiorly and posteriorly, and that actually results in straightening of the lumbar spine, and then pubic symphysis is actually anterior to the ASIS, whereas in the anterior pelvic tilt the pubic symphysis is posterior to the ASIS. During the normal conditions, there's actually a slightly pelvic tilting in terms of anterior pelvic tilt, but we usually say that as neutral, but it isn't in the true neutral straight sort of. Now, moving on, what is actually the force coupling that is occurring in the sital plane for the anterior and posterior pelvic tilt? It is very important to understand because a disruption in this force coupling actually results in the lower cross syndrome. And what is lower cross syndrome? We're going to talk about it in the detail. So there are actually two different couples. One couple is actually trying to tilt the pelvis anteriorly, and one couple is trying to tilt the pelvis posteriorly. So the couple which is actually trying to tilt the pelvis anteriorly are actually the hip flexors, which are the iliopsoas, and the back extensors, which are the lumbar erector spinae. So hip flexors try to pull the pelvis into anterior pelvic tilt by pulling the ASIS inferiorly, and similarly back extensors pull the PSIS superiorly, and thus promoting anterior pelvic tilting. On the other hand, in terms of posterior pelvic tilting, the couple that is acting is the hip extensors or the gluteus maximus and the trunk flexors such as the abdominals, and the hip extensors pull the posterior superior spine inferiorly, and the trunk flexors pull the anterior superior spine superiorly, resulting in the posterior pelvic tilting. Now, what happens in the lower cross syndrome, the muscles which are actually prone to get tight are the hip flexors and back extensors, and this couple actually supersedes or it dominates the posterior pelvic tilting couple. So what happens is that there is actually shortening of the hip flexors, shortening of the back extensors, weakness of the hip extensors, and weakness of the trunk flexors, and that actually results eventually in the increased or exaggerated anterior pelvic tilt and exaggerated lumbar lordosis, exaggerated thoracic kyphosis, and that can eventually lead to exaggerated cervical lordosis as well. And if there is exaggerated thoracic kyphosis and cervical lordosis accompanied with the lower cross syndrome, so that actually becomes a kypholordotic posture. Now, talking about the pelvic movement in the frontal plane. So in the frontal plane, we have the lateral pelvic tilting. Either the anterior superior iliac spine on one side is raised or on the other side is raised. So in the neutral, both anterior superior iliac spine or the both iliac crest are actually at an equal level. But if one is raised and the other is lowered, then that is actually known as the lateral pelvic tilting, and that actually happens during walking as well. When we walk, what happens is that when the leg which is being lifted, there's actually pelvic hike at that leg and pelvic drop on the leg which is supported. In this picture, we are seeing that there is a pelvic drop on the leg which is being lifted, which is actually known as the Trendelenburg sign. Moreover, when we talk about the other joints which are being affected, so not only is there a pelvic tilting, but with the pelvic tilting, there's abduction at the level of the hip, as well as there's the contralateral rotation at the level of the spine as well in the frontal plane. Now, talking about the force coupling, so the force coupling is that, for example, if there needs to be a pelvic tilting, so if I'm talking about the right hip abductors, so they contract to abduct the hip on the right side, whereas the left trunk lateral benders, such as the quadratus lumborum, they actually contract to hike the pelvic towards the from the left side, and that actually results in a lateral pelvic tilting towards the right side, or you can say in this picture we would say anti-clockwise rotation that is being occurring, and that is actually how the force coupling occurs in the frontal plane between the lateral benders of the trunk, such as the quadratus lumborum, and the hip abductors on the contralateral side. And then another movement which is possible at the level of the pelvis is the pelvic rotation. Or pelvic rotation is actually the pelvic movement in the horizontal plane. So what happens is that the pelvis can either rotate in terms of, for example, this one is the right side and this one is the left. Either the right rotates anteriorly or the left rotates anteriorly. So if the right rotates anteriorly, so this is known as anterior rotation of the right side, or the anterior rotation towards the left side. And if the left moves anteriorly, so it is the anterior rotation of the left, or the anterior rotation towards the right. So that is very important to understand the terminology, how we are going to describe it in terms of biomechanics. So if we talk about this, so this is neutral. We can see any structure, for example, both ASIS are at the same level, or any structure that we're actually trying to observe, they would be at the same level. So, and this picture, if this is the right side, so this is moving anteriorly, so we can say the pelvis is rotating towards the left side, because the right side is moving anteriorly. And similarly, if we take a look at this picture, there is actually the posterior rotation of the left side of the, you can say posterior rotation of the, posterior rotation of the right side of the pelvis. And if we take a look at the hip joint, there's also a movement which is occurring at the hip joint. When there's anterior movement of the pelvis, or we can say the anterior movement of the right innominate bone, there's actually internal rotation at the contralateral hip. And when there is actually posterior rotation, or the posterior movement of the, let's suppose, the right side of the innominate bone, there is actually external rotation which is being occurred on the contralateral side, or the contralateral hip joint. So anterior movement of one side of the pelvis or the innominate bone results in the rotation of the contralateral side of the hip joint, or the contralateral hip joint. If the pelvis on the one side moves anteriorly, there is contralateral internal rotation. And if the pelvis moves posteriorly, there is contralateral external rotation. And that's how the pelvic movement occurs in the horizontal plane. That was all about the motions and the movements that occur at the level of the pelvic girdle. I hope you learned something new out of it. Keep on watching sqadia.com for more lectures like this. Thank you very much.